Buenos dias, good morning. Thank you for having us. So today I will be discussing death by neurologic criteria, facts, fiction, and practice updates. I will be very interested when we are done with our talks to hear more about how you do this in your daily practice, if at all. So in terms of disclosures, I have no relevant financial disclosures, but I do have a personal interest in the topic. I am on my Hospital Organ Donation Council committee. I am the creator, the writer of our hospital policy for the Declaration of Brain Death, and I'm also the course director and instructor for several different educational programs that we do for our residents and physicians in terms of how we diagnose brain death and how we communicate the diagnosis of brain death. So for objectives, we will discuss the historical perspective of how the evolution or the concept of brain death has evolved, the importance of clinical testing, the use and what we should consider to use for ancillary testing, and why it's important to avoid practice variation. Finally, at the end, we'll discuss how we want to communicate that diagnosis and why it's important to include families in this discussion. And we'll summarize the guidelines and practice updates, and I have a couple of cases at the end. So when we think about brain death, we have to actually think about it in a historical context of how critical care and ICU evolved, because we couldn't keep people alive until we were able to resuscitate them and put them on ventilators, right? So people didn't exist in comas until we actually had intensive care units and were able to keep these people alive. So this is a timeline showing how that process evolved. In 1947, that was actually the first successful cardiac defibrillation. And then we had the development of positive pressure ventilation in 1950. So people that could not breathe on their own, especially with the polio pandemic, were able to be kept alive with the use of these ventilators. In 1958, Dr. Safar actually developed mouth-to-mouth resuscitation. I trained at one of the hospitals that he worked at, and there's a lot of stories about how he would actually pay medical students to become paralyzed, and that is how he developed the process of mouth-to-mouth resuscitation. I don't think that's something people would allow in these days, but that's actually how we developed the process of CPR. And then once we're able to keep these people alive, physicians, both intensive care and neurologists, were saying, we have these patients that are on a ventilator, but they're comatose. What do we do with them? And there were two kind of groups of neurologists. There was the French camp, who described this as coma dépassé, or beyond coma. And then there were the American neurologists that said, this is the death of the nervous system in these patients. And we started to develop an idea or a framework for how we would diagnose brain death. And they actually described 4 stages of coma, meaning you were not breathing, you did not have brainstem reflexes, you had an isoelectric or flat EEG, and they said that this is 100% mortality. Now, it was a few years later that Dr. Schwab, who was at Mass General, kind of took this step further. He had a patient with an intracranial hemorrhage in the ICU, and he said, they don't have brainstem reflexes, they're not breathing, they have a flat EEG, I think this person is dead, and I'm going to take them off the ventilator. And that was one of the first cases of documented declaration of brain death. As you'll see, I'm going to keep showing you further, we do end up having a formal policy developed in 1968, but there's decades of confusion that follows. So Dr. Schwab, he's the physician I just discussed. He first did this with a patient, diagnosed it in 1966, and he called this dead in spite of cardiac action. The patient's heart is beating, however, they're not breathing, they're comatose, and they have no evidence of brain function. So this was the initial proposed criteria. In 1968, this was published in JAMA, the Journal of American Medical Association, as a definition of irreversible coma, definition of brain death. And the wording they used is, any function, brain or other, that no longer functions and has no possibility of functioning is for all practical purposes dead. So this was published in 1968. However, as we move through time, there's a lot of confusion. In the 1970s, when there were surveys of neurologists, about 15% still said cardiopulmonary death is death, and there is no such thing as brain death. And then we see a lot of variation in terms of states within the United States and countries around the world in terms of how we practice this, if we practice this. So in the 1980s, there was a presidential commission to address this problem, and there was a law developed. It's abbreviated as UDDA, which is the Uniform Determination of Death Act. And essentially, that gave legal representation to death in that you can die two ways. You can die when your heart stops, and you can die when your brain stops working. So they defined it as irreversible cessation of circulatory and respiratory functions, or irreversible cessation of functions of the entire brain, including the brainstem. So this is a very important law that basically gave power to the definition of brain death, saying you can die through cardiac death or cardiopulmonary death, or you can die through brain death. However, the problem with the UDDA is it says this is death, but they did not specify the criteria, and this is what has led to a lot of subsequent problems and confusion. So in the 1990s, Dr. Elko Widgix, who's at Mayo, developed some American Academy of Neurology practice parameters, which is what we started to kind of follow. So it was defined as coma, being unresponsiveness, absence of brainstem reflexes, and this is really when we developed one of the first apnea testing protocols. In this point in time, it was determined that you can use a confirmatory test, but it's not mandatory. However, if you cannot complete your whole test, it's something you should think about doing. Now, I put this up to show you how, despite some guidelines that have evolved over those decades, there's a lot of variation around the world. So this study looked at different countries to say whether nations are following whole brain death, meaning you need supratentorial loss of function involved with brainstem loss of function, or just brainstem death. Is it one physician or is it two physicians? Do you just do your clinical exam, or do you also need ancillary testing? If there's two tests done, how much time has to pass between tests? And as you can appreciate, there's a lot of variability. In some countries, it's one physician, and some it's two. Some it's whole brain, some it's brainstem. Some you have to get ancillary testing. You have to get more imaging to confirm lack of blood flow, and others you don't. So this just reflects the amount of variation that exists. And it's something we absolutely do not want, for someone to be considered dead in one country and not dead in another. It's very confusing for family members, for the public, and it's also confusing for physicians. This is another study showing the amount of practice variation that exists, and this is based off of the 2010 AN practice parameters. I highlighted a few interesting points here. So I wanted to put here that, and this one particular study is in the United States, but they looked at different hospital guidelines, and of those guidelines, only about 42% required involving a neurologist or a neurosurgeon. I don't know about you, but a lot of the physicians I encounter that don't practice neurology don't like it, aren't comfortable, aren't even scared by it. But there's a significant amount of those people that are actually declaring brain death, which can be a scary thing to think about. In this paper, what they actually found was there was a high amount of physician involvement from neurologists and neurosurgeons. However, when it came to the actual declaration of brain death, only 43% of these patients were declared by someone in this specialty. And the even more frightening thing to think about is only 44.7% met the actual parameters that are set forth by the Academy of Neurology. So I talked about the practice variation globally in terms of policies, protocols, but what about ancillary testing? That's one of the pieces that is also confusing. Do we need to get it? And this just shows globally what countries either require it, say it's optional, or it's unknown. So you can see there's quite a bit of variation there as well. I tried to find published data in the Dominican Republic regarding brain death here, and there was not a lot. I did find this paper that looked at determination of death by neurologic criteria in Latin America and the Caribbean countries. And essentially what they did is they went through, looked at protocols that exist in this region, and the panel of authors are actually very highly known on this topic, and they reached out to people they knew in this region. And so they reached out and they said, how many of these people have access to a protocol? Of the 33 countries they reached out to, 30 responded, and 16 had protocols for brain death of the declaration of neurologic criteria. And of those 16, only 13 actually defined brain death. 10 referred to whole brain death, but there is a lot of variation, just as we've seen within the United States and globally, where there's a different amount of exams required, different prerequisites, and different descriptions of the clinical assessment. Some did give protocols for apnea testing, and Brazil and Panama do require ancillary testing, but there's variation in terms of when to use and what testing to use. The authors did specifically indicate that the Dominican Republic and their contact informed that there was no existing protocol. However, they did find a published study that cited medical legal criteria that is specified and that there are institutional protocols. So my takeaway point is that it seems like it is not well defined in this country. I'll be interested in hearing more from you, and that there likely is a lot of variation in practice. So in terms of defining death by neurologic criteria, we want physicians to be comfortable in doing this because it is one of the diagnoses we absolutely do not want a false positive. The process should be consistent amongst hospitals, states, and countries because, as I mentioned, we don't want someone to be able to be declared dead in one country and alive in another. We want to avoid that. So I will be highlighting some changes that were published in the most recent guideline update. This was published in October of 2023. It was a very highly anticipated guideline update because in the more recent guideline updates, there was still variation even amongst societies. The Neurocritical Care Society, the Society of Critical Care Medicine had different variations. So this was a really nice way to get everyone together, and it also included the Congress of Neurological Surgeons so that everyone could really be on the same page. And they also combined adult and pediatric criteria because previously there were separate guidelines. So in terms of prerequisites, I think one way to most safely proceed with brain death testing is to make sure it's appropriate to even start doing it. And one way to do that is to make sure you've satisfied the prerequisites for moving forward with brain death testing. So number one is that you need evidence of a catastrophic irreversible brain injury. If you don't have evidence of some significant and severe brain injury, you should not be doing brain death testing. So that's step one. Step two is then thinking about their exam. And again, this is when you've removed confounders such as sedation, and I have an extensive list I'll show on another slide. So they have to be comatose. No purposeful reaction to central or peripheral noxious stimulation. They have to have a total lack of brainstem reflexes and no spontaneous breathing. You also want to think about, could this be a mimic? There are severe cases of Guillain-Barré or AIDP, botulism, snake bites, rabies that can mimic this. But if you go back to making sure you have your evidence of a brain injury, you shouldn't get fooled by one of these mimics. And then you're going to think about your confounders. So medications. This is probably one of the biggest things we get called about from other ICUs when there's consideration for doing brain death testing is, can we do it? They were on this medication. We take care of a lot of overdose patients. How do we assess when is the right time? I will show you a picture, but the new guidelines have very nicely created supplements in terms of very clear guidance by medication, how long you should wait for each medication. But the takeaway point is that you need to wait at least 5 half-lives for each of these medications before it's appropriate to consider testing. But that's if someone has normal renal function, normal liver function, is a normal size, because all of these things can affect your metabolism of the drug. So you want to take all of this into consideration. The most common ones that we typically see, or if they're already in the hospital, would be sedatives like propofol, dexmedetomidine. If they're coming in with an overdose, likely narcotics. This is one of the supplements I was referring to. The guideline is free to download if you just Google AN Brain Death Guidelines 2023. And when you get to the guidelines, click through the supplements. This is a very useful one that highlights all the medications, how it's metabolized, how much time you need to wait, and it's extremely valuable information. When we're thinking about confounders and ways of excluding, it's not recommended to routinely do toxicology testing, but if it's appropriate based on the history, you should do that. If there's any concern about pharmacologic prophylaxis, you want to check a train of 4. So if it was someone that had been paralyzed for severe pulmonary issues like hypoxia, you want to make sure that that has been cleared with a train of 4 testing. And you want to make sure there's no severe electrolyte, acid-base abnormalities. This is another one that became problematic because in the old guidelines they said, avoid confounders, no electrolyte problems. But what does that mean? Like, what number, what sodium should we avoid? A lot of these patients develop diabetes insipidus and become very hypernatremic. So at what point is it appropriate to do brain death testing? So in these guideline update, they provided a supplemental guidance listing some of the more common things that come up. I'd say in my practice, typically hyper or hyponatremia are the two big ones. So if the sodium is above 160, and it looks like they're in diabetes insipidus, I will say, treat with vasopressin, give fluids, let's recheck a sodium before we move forward. If the abnormality is just too significant to correct, then you'll start thinking about getting your ancillary testing. BON is another one because a lot of times these patients might be in renal failure. So you just want to make sure you're going through all the labs, all the data, all the medications, and making sure there's nothing on board in that patient that could potentially change your exam. This was a published case that I thought was important to include because it really shows the power of how much medication can confound our exam. So this was a published case of a 40-year-old woman who was found unresponsive by family, presumed overdose. They gave her naloxone and she was intubated, but she was comatose. Essentially, GCS of 3, didn't have any brainstem reflexes on the first day. They put her on EEG. It just showed burst suppression with some sharp waves, but a very flat background. So a few days into her hospitalization, they called Neurology. They actually did a brain death exam. I mean, I couldn't believe this when I read this, because if we go back to what we thought about, you need evidence of severe brain injury, right? And that's not the case here. If they had done a head CT first and showed there's no significant anoxic brain injury, no big hemorrhage, they wouldn't have moved forward with brain death testing. They said it's a poor prognosis, and they were actually planning for donation after cardiac death, meaning they told the family, she's not going to wake up, this is a bad outcome, we should remove her from the ventilator and donate her organs. And the day that discussion was had, she opened her eyes. And 2 weeks after being admitted to the hospital, she was discharged to a psych unit, back to her normal self. So this just shows you why we go through these lengths to make sure it's appropriate to do testing, and why there's nothing in terms of medication, electrolyte abnormalities that can change your exam, because there are instances like this, and this is something you obviously would not want to make the wrong decision for these patients. Another key finding that can kind of help you distinguish is pupillary response. And this is a big thing I tell people who are non-neurologists to think about, that if the pupils are smaller than you would expect or larger than you would expect, those can be hints to other things going on that could give you clues to other kinds of intoxications or overdoses. So moving forward, we'll kind of talk about the brain death testing. So it was previously referred to as brain death, which is more of the everyday term. The guidelines do refer to it in medical terminology as death by neurologic criteria. So you might see the abbreviation of DNC. And essentially, you have your clinical exam and your apnea testing. So as we mentioned, the patient's comatose. They're non-responsive to tactile, auditory, or visual stimulation. There's no cerebrally mediated movements when you give them noxious stimulation. And there's no brainstem reflexes. We'll talk about some ancillary testing that can be used. However, you only use those ancillary tests if you cannot complete your physical exam. So if you can do your exam, you do your clinical exam, you do your apnea testing, and that is sufficient for brain death criteria. Hospitals in the US do vary in terms of how many exams you need. You need at least one. I've been at some hospitals where it's one exam and one apnea test. My current hospital does 2 exams and 1 apnea test. You only get the ancillary testing if you cannot do those other testing. Because one of my personal pet peeves and annoyances are when other intensive care units order ancillary testing before even doing the clinical exam. That's not appropriate. You always go back to your clinical exam. Some examples for when it would be appropriate to do ancillary testing. I see a lot of traumatic brain injury, gunshot patients, so if there's been someone that's been shot in the head and I can't assess, they might not have an eye, or they might have several skull-base fractures, and it's unsafe to do oculocephalics or vestibulo-ocular reflexes. I do as much of the exam as I can, but I'll need ancillary testing in those patients. If people have a spinal cord injury, right? and they're quadriplegic, you need ancillary testing because you won't know if they can react to purposefully to noxious stimulation. So those are the most common ones. For people, I will also say with severe underlying pulmonary issues that are maybe CO2 retainers, those are the patients that also likely need ancillary testing. So in terms of the biggest changes from our prior guidelines to the most recent, they gave those very detailed specifications for how to look for confounders. The temperature. So we've always known 36 degrees. You can't be cold and dead, you have to be warm and dead is what people say. So it has to be at least 36 degrees Celsius. But in the new guidelines, they go even further to say that if your temperature is under 35.5, you have to re-warm to 36 and maintain there for at least 24 hours before doing your testing. Previously, if I had a patient that was hypothermic at 35 degrees, I would warm them up to 36 and do my testing then. But now we have to wait 24 hours. In adults, the old guidelines say you have to be hemodynamically stable, which is vague. Now we have very specific criteria that the systolic blood pressure must be at least 100 and the mean arterial pressure must be at least 75. And that's because if we don't have adequate systemic perfusion, we're not going to have adequate cerebral perfusion. And how can you say there's no blood flow to the brain if you're not giving a chance for there to be adequate blood flow? So this is one of the most important changes that has occurred. The clinical exam, I'm sure you're all familiar with this, but essentially you'll be doing your coma exam, you'll check for reflexes. The pupillary response, as Dr. Shepard mentioned, a lot of hospitals are now using pupillometers. So each of our units has one pupillometer, and I try to use those in these patients because I'm sure you've had challenges where people have dark irises, or it can be very challenging to differentiate between a non-reactive and a sluggishly reactive pupil. So it can give you hard evidence that it is definitively a non-reactive pupil. We look for ocular movements by doing our oculocephalics and vestibular ocular reflexes, absence of any facial movement to noxious stimuli, and then we'll check our gag and cough reflexes. One thing that people can get really confused by are reflexive movements. So we talked about an absence of purposeful response, but especially non-neurologists get confused when they see a triple flexion or they see a spinally mediated response. So that does not involve the brain. Therefore, if you see that, you can still proceed with brain depth testing. I will say that if you have any concern that it's unclear or you're uncomfortable, then add your ancillary testing. But in terms of these reflexive movements, they're typically reproducible, very stereotyped. And I would refer you to this paper. It was published in Neurocritical Care that actually gives a whole summary of the different spinally or non-cerebrally mediated reflexes that are seen in brain death that can often be confusing to physicians and families. So we'll talk about this in a little bit, but I will explain to family members, we might see some movements, but they're movements that don't involve the brain. It involves the spinal cord. But again, any concern that you don't understand what's going on, get ancillary testing. So also included in the guidelines are these wonderful summaries and checklists. So when I was creating our hospital policy, I worked directly off this checklist, and as I'll show you, we created a navigator within our electronic medical record, so it's as simple as possible for people to move through things without missing anything. This is just an extension of the checklist showing what you need to do for your clinical exam, and it also goes through making sure you've assessed for confounding factors. In terms of apnea testing, as we mentioned, people have to be normothermic and normotensive, and you have to start with a normal arterial blood gas. So that means you're going to pre-oxygenate these patients on an FiO2 of 100%, and then on your baseline ABG, you're going to get a PaO2 of over 200, and you're going to have a normal ABG. So in the prior guidelines, it was described as normal. But now, as you'll see on the next slide, there's very specific criteria for what there has to be. There's different ways of completing your apnea testing. You can disconnect from the ventilator and essentially just take a nasal cannula at 6 liters and put it down into the ET tube. Some people will just connect to a PEEP valve. So if you're concerned about someone had been on a higher PEEP setting on the ventilator, you're worried about atelectasis or de-recruitment, it can prevent that from happening. And then you're monitoring for respiratory movements. So typically I have at least one person at the foot of the bed monitoring the patient for chest rise. I always also explain sometimes the heart beating can be confusing because it might look like the chest is moving, but that's different from chest rise with inspiration and expiration. And I have someone keeping an eye on the monitor because you're going to be monitoring for hemodynamic instability. You would be surprised that these patients don't desaturate. If anything, they might have blood pressure variability, heart rate variability, and you can titrate medications as needed to control that. So in terms of the key revisions for apnea testing, your ABG that you obtain prior to testing has to have a normal PCO2 of 35 to 45, a pH of 7.35 to 7.45, and a PaO2 of over 200. Now, hospitals will different practice in terms of how often they're sending arterial blood gases. At other institutions, I could send a blood test and have the results within minutes. So I would often send them more frequently because if I get the result I need, I will stop testing. At my current hospital, I don't have test results that quickly, so I'll send an ABG at about 8 to 10 minutes, and then maybe every 5 minutes from there. And if you get an ABG with a pH that is under 7.3, a PCO2 of at least 60, and at least 20 higher from your increase in your baseline, that meets criteria. So you reconnect them to the vent. You will have to then hyperventilate them to renormalize the ABG, because they'll be acidotic at that point. But that is essentially your time of death. You've completed your clinical exam, you've gotten your apnea testing, and I prepare families for this, and I explain to them, if we get this blood test and it shows these numbers, the time that that test results is the time of death. And we'll talk a little bit more about that in a moment. One caveat for, again, patients that might have chronic hypercarbia, these are patients with severe, significant lung disease. You still do the testing, however, you likely will need ancillary testing because it's hard, you just can't correct some of these patients. They live in a chronic respiratory acidosis. So this is another checklist just showing how you perform your apnea testing, and it's a nice way of showing what needs to be documented. Do you see patients on ECMO, your group, ever? Extracorporeal membrane oxygenation? Those are patients with maybe severe heart failure or pulmonary issues? No? Yes? Okay, yes. So I will say there's a separate protocol. It's a little bit different for patients. You can still do an apnea testing for patients on ECMO. However, you either have to adjust the sweep or add back exogenous carbon dioxide. And then when you're drawing your ABGs, you have to draw it from their distal, the patient's distal arterial line, as well as the post-ECMO oxygenator circuit. It should meet criteria on both of those. So a few other key policy changes. If you do have 2 exams that are required, there's no time interval between exams. So one physician can come in and do their exam, and then the next one can come. There's no minimum time. Now, in terms of when it's appropriate to do, most of it is left at the discretion of the physician. However, in patients with hypoxic ischemic brain injury, so these are patients that have had a cardiac arrest or profound hypotension that evolves into anoxic brain injury, you must wait at least 24 hours in those patients before proceeding with testing. They also added a statement on pregnancy and neuroendocrine function, meaning that if someone is pregnant, you can still proceed with brain death testing. There's obviously a lot of ethical decisions that go into this, depending on how far into the pregnancy the patient is. It typically involves having someone from OBGYN or maternal fetal medicine, an ethics representative from your hospital. It's something we don't deal with often, but it can happen. And then neuroendocrine function, because I'm sure you've seen in the news there have been cases where people still have menses, menstruation, because they still have neuroendocrine function. And they say, how can you be brain dead if you still have neuroendocrine function? But we now know that that is allowed. So that does not preclude you from doing brain death testing. And in terms of ancillary testing, EEG is no longer acceptable. It used to be considered one of the tests available. It had to be done in a different protocol, very sensitive setting. However, we know that an EEG in an ICU is prone to a lot of artifact, and it's just not the best test to be used. And it also is going to capture what's going on supratentorially and not necessarily what's going on in the brainstem. So a brief word on ancillary testing. These are what is recommended. So you have DSA, digital subtraction angiography, which is an angiogram where you would call your neurosurgical or endovascular colleague, and they basically go up with the catheter, and there's no blood flow. At most of the institutions I've practiced in, the nuclear imaging is the preferred choice, where they basically will inject an isotope and take pictures at different time stages, and you see no blood flow. So this is an example. This head CT is clearly diffuse cerebral edema, likely a patient with anoxic brain injury, and then this is called the hollow skull sign. This is your lateral, this is your AP view, and you can see that it's totally empty here, so lack of blood flow. And in the instance where you're getting ancillary testing, the time of that report will be the time of death. At our hospital, we do have an on-call nuclear medicine tech that will come in to do this any day or time. Transcranial Dopplers are also allowed. However, this is kind of our personal studies where we only use when a patient is too unstable to be transported to any other space. Because with transcranial Dopplers, they're prone to a lot of variation in terms of who's doing the study. And about 10 to 15% of people will have hyperostosis or thick skull, and you might not be able to insulate the vessels very well. So this is just a summary of what the different kinds of ancillary tests are in terms of looking at brain flow. You can see here that DSA, about 100% specificity and sensitivity. When we go down to nuclear perfusion, you get very close to 100 as well. So this is just a picture of what we use in our medical record. So we have what's called a navigator. So when I go into the patient's chart, there's a brain death navigator, and we created a policy, and then we work with our technology people to change the policy into this navigator. So everything is listed so that when someone who doesn't do this often can log in and just go through, yes, it's appropriate, yes, I've done this, yes, they're ready, I've reviewed their medications. And it just minimizes the variability and minimizes the chance of there being a mistake happening. And this is how we enter in the apnea testing prerequisites and the results. And then that will eventually import into what we call a brain death note. If we do ancillary testing, we have to check off why we did it and then which testing we did. So this are some nice summaries that are included in those new guidelines I alluded to. Really nice flow chart just showing when it's appropriate to think about brain death testing and when it's not. Briefly, a couple slides on consent and the ethics and legal aspects. So, some people will say, brain death testing is a test. I have to consent for tests. My doctor has to consent me. However, brain death is death. It's legal death. If someone has a cardiac arrest, we don't consent families to say, can we declare them dead? So there have been some lawsuits amongst different states where people have claimed that there should be consent, and this is one of the problems that has arisen from that UDDA, where they weren't very specific on what criteria is required. I will say in terms of objections, there's only one state in the United States where a family can object based on religious reasons for doing brain death testing. So every other state, it's vague in terms of you have to make accommodations for family members. You might have to give them some time to do some special prayers or rituals. However, New Jersey is really the only state where a family can refuse. And I have had actually patients try to get transferred because we tell them we're going to declare brain death, and then they'll try and get them to this state so that that can't happen. Now, I included this. I usually include Grey's Anatomy on this slide, but I tried to find more relevant telenovela medical shows for you. But the reason why I always include this slide, yeah, Grey's Anatomy is the one I usually use, is that for some people, this is all they know of medicine, right? They see it on TV. It's not realistic. People go in, dead, dying, and then they leave the hospital a few days later. That's not how things work. So I think it's really important to remember that we have to be really good at explaining things to family members because this is the only access they have to medicine in some cases. So this was a study I found that looked at knowledge of brain death, and they actually looked at a group of Dominican immigrants that had moved to Spain and Florida. And what they did is they actually looked at, do these people understand what brain death is? They looked at late qualified adults as being over 15 years old. They had 123 respondents, about half in Spain, half in Florida, and a third basically understood that brain death is death. About half did not know what brain death was. And about another quarter said, I don't think brain death is death. So I think if you look at this, 75% of these people either don't understand what brain death is or have the wrong idea about what it is. So there's a lot of work that has to be done in terms of public awareness and education. So this brings me to one thing that I feel very strongly about is involving families in this diagnosis. So we have evidence to show us that when families are involved, they understand better. So this is actually a randomized controlled trial that took family members of patients that were going to be declared brain deaf and put them in one group that said you'll be here at bedside with brain death testing and another that was not. And they were given a test to see, this is the questionnaire you can see, you know, is brain death? Like, will they ever wake up? And what they found is that in family members that were present, they had a significant increase in understanding what brain death was. So here this is showing before, they're about the same in terms of their scoring on this test. For the people that are present, their score significantly increased. And what I found also interesting is they followed up with these families at 30 days, 90 days, and there was no PTSD, no trauma, no other emotional issues that came out of being at the bedside. So I always offer family members the option to be there as I'm doing testing, and I explain to them every single reflex, what I am doing, if the reflex is there, what you should see. And for some of these difficult family situations, I think it can be very helpful for them to process what's going on. So communication is key. I always summarize the reason for admission. I go through imaging. I always explain there's two different ways you can die. You can die from cardiac death, you can die from brain death. And I explain what the process for testing is. I offer them the ability to be present. And then I always make sure they understand this is the time of death. You have to use that word, because otherwise it's already a confusing topic, and you want to be as very clear as possible. And languages matters. You know, we always say, oh, this person's on life support. But if we declare them brain dead, they're on organ support. They're not alive anymore. The ventilator is organ support, not life support. And one thing that, because I feel like my discussions last night, people don't practice this regularly, on the physician side, we never discuss organ donation with these families. That's actually not allowed, because we don't want families to think that we have something to gain from them dying. So we are separate from that process. So I talk to families about what brain death is, how I declare them brain dead, and I say there are other people, other teams that will come in to talk to you. And if they ask me about it directly, I say, I'm not involved in that. I will send someone in to come talk to you. So for ethical reasons and for just the clear understanding and comprehension on the family side, everything is separate. So in terms of takeaway points, having hospital and institutional policies to standardize practice is important, but I think in the Dominican, it sounds like you actually might need a law statute to be very clear about how we define death and that there are two ways to die. Educating medical staff is really important. That includes everyone, nurses, physicians, respiratory therapists, everyone that's involved in the process, because we want to be able to communicate one clear message to family members. And then practice for trainees. So this is really important for me. I run several programs for our residents in terms of how to do testing, how to communicate the diagnosis, and for the American Academy of Neurology, this is actually a core requirement for them to graduate training, is to be able to understand how to declare brain death. And public initiatives for awareness is important as well. So I have two quick cases. The first one, so 40-year-old, and this is someone actually, this is a real case I saw. 40-year-old woman, she developed some slurred speech over a couple days, and her family brought her into the hospital, and it was noted she had difficulty breathing. So while she was in triage, she was intubated because she looked like she was about to develop respiratory failure. She gets admitted to the ICU, and they consult you about 6 hours later. When you see her, she's comatose. Her pupils are non-reactive, they're 6 millimeters. Her eyes are midline. She has no corneal reflex, no gag reflex, no cough, not spontaneously breathing, and she has no response to noxious stimuli. Do you think it's appropriate to proceed with brain death testing? I hear no, so why? What would you want? Do you need more testing, or why are you saying no? This is on the checklist, but what does it say on the checklist? Exactly, so how do you help sort out the etiology? CT, so one of our favorite things, CT. Yeah, so we don't have, like we mentioned, you need radiographic evidence of catastrophic brain injury. I did not mention that here. So in this patient, we got a head CT. This person actually, this was when I was in fellowship, she came in the middle of the night, I saw her and I said, clinically, she looks like she's brain dead. And I got a head CT and it was normal. Normal. So then you have to really start thinking, what's going on? So you're going, yeah, I heard medications, you're thinking about confounders. So this ended up being a complicated case. She had botulism, but so very severe botulism to the point where she had no cranial nerve reflexes, wasn't breathing. So we got the head CT, it was normal. We got an EEG, it showed normal sleep architecture, and that's when we said, okay, we need to start thinking about the weird things now, and we started working up other things. So just remember, you can clinically look like brain death, but if you don't have radiographic evidence, you need to start thinking of something else. One other case. So this is a 75-year-old man. He was found down at home by family. He initially was a very bad exam, a GCS of 3, and he's intubated. He's hypertensive with a systolic of 260, and he's thrombocytopenic with a platelet count of 65. As you can see, that has resulted in a very large intracranial hemorrhage. On his initial exam, he only has one cranial nerve, which is a cough reflex. He's admitted to the ICU. He's treated with hypertonic saline, and you're discussing with your neurosurgery colleague, can we do a decompression or a clot evacuation? Then you get called by the nurse that he's hypotensive, there's high urine output. You reassess the patient, and he doesn't have that cough reflex anymore. There's no reflexes. So do you think it's appropriate to proceed with brain death testing? No. Why? There's a couple answers. Right. So hemodynamically, yes, we haven't met that criteria. We might have to start a pressor or volume resuscitate. One other one, which is a little bit trickier. Hypertonic saline. So received hypertonic saline. That, in addition to the high urine output with someone with this imaging, I'm worried about them developing diabetes insipidus. So there's two potential things going on that could cause pretty significant hypernatremia. So I'd want to get another set of labs and assess what the sodium is. I mean, I think we can agree that this patient likely will become brain dead, but we need to, do the checklist and make sure we're not missing something. So I'd repeat labs, correct their blood pressure, and then, if appropriate, proceed with testing. This is from a safari Dr. Shepard and I went on a couple weeks ago. Thank you so much.